quality care to the South Los Angeles community. Throughout her career, Dr. Batchelor's #1 priority has been to improve access and quality of care for underserved communities, utilizing innovative and collaborative approaches. There's that word collaborative again. Her work
Out how to get my slides up here.
Escape.
Escape.
And then reduce. Double tap here. Go to go on slideshow right there. There. And then from beginning.
Great. Okay. So I get to start you off by talking about health and health equity. The title of my presentation is Promoting Health Equity in South Los Angeles. And I'm going to talk about South Los Angeles and the problems that we face there as an example of many other underserved communities. And I'll talk about the challenges, but I'm also going to talk about what we're doing to start to turn around some of the conditions that we face in South LA. So this is a little outline of what I'm going to say. I'm going to talk first about health disparities that are affecting us as African Americans in general. And then I'm going to zero in on the community of South LA and talk about what we see in South LA. And then what we are doing about health disparities by opening a brand new state-of-the-art hospital and health system in the middle of South LA. Our ongoing challenges, and then because this is a policy conference, I'm going to talk about some of the issues that policymakers and advocates can help us with. So the first thing I'm going to do is quote you a couple of definitions. The first is the definition of equity: the absence of avoidable or remediable differences among groups of people. And health equity: the Centers for Disease Control tell us that health equity is when everyone has the opportunity to attain their full health potential, and no one is disadvantaged by social position or other social conditions. Unfortunately, equity and health equity is not what we have in this country with regard to African Americans. Instead, what we have are very significant and long-standing health disparities. And I put a couple of those disparities on this slide just to illustrate the range of the problem and the depth of health disparities that are facing the African American community. So, 60% more likely to have diabetes and the complications associated with diabetes. We are 30% more likely to die of heart disease. As women, as African American women, we're less likely to get breast cancer, but we're 40% more likely to die when we do get breast cancer. Our men are twice as likely to die of prostate cancer, and our babies are twice as likely to die as infants. Adolescents are 30% more likely to attempt suicide and less likely to get counseling for depression. There are only 2 procedures that we get more of: amputations as a result of diabetes and vascular disease, and castrations for advanced prostate cancer. The range of personal, social, economic, and environmental factors that influence health are known as determinants of health. The determinants of health and the underlying causes of the health disparities that I just talked about are multifactorial and interrelated, and definitely require collaboration to address. I'm going to be talking about collaboration from the health side, but other panel members here will bring in other aspects of these underlying causes of health determinants. So when people think about health, they think about healthcare first. But healthcare is actually the factor that has the least influence over health. At the top of the list of health determinants are social and economic factors that I've listed up here, and they account for about 40 to 50% of health status. So these are things like poverty, unemployment, lack of good education, poor housing, lack of transportation, social support, lack of access to healthy foods, not having safe places to recreate, exposure to violence and crime, and exposure to physical environmental toxins like air pollution and unsafe water. And then another big driver of health is individual behavior, which accounts for about 30% of health status. And that includes our habits like smoking and drinking and substance abuse, overeating and physical inactivity. And then biology and genes. We're stuck with our genes, but fortunately only 10% of health is determined by biology and genes. And then healthcare, which is important, but again, not as important as some of these other factors. But affordability, availability, and quality of healthcare are big factors. Now I'm going to switch a little bit, and I'm going to talk about the community of South Los Angeles, which is where I work. And as I said, it could be any other inner city community that's medically underserved and that has more than its share of social determinants of health. So the area of South Los Angeles is located in the middle of LA. We call it the hole inside of the glazed donut. It includes the areas of Watts and Compton, and it's home to over 1 million people. It is predominantly ethnic minorities. It used to be predominantly African American, but as an example of demographic change, it is now predominantly Latino, although still has a sizable African American population. Low income, and most of the residents who live there use public transportation. So getting out of that community is a challenge for them. LA is not a city known for having great public transportation. Large portions of South LA are federally designated as both health professional shortage areas and medically underserved areas. What this means is that these areas have a significant shortage of physicians and other healthcare professionals. We are missing 1,700 physicians in this community. 1,700. 700 primary care, 1,000 specialists, not to mention other types of healthcare professionals. So as you would expect, in a community that's low income, that doesn't have enough healthcare resources, we see very significant health disparities and problems with access to healthcare. We have the lowest life expectancy in LA County. You may ask me, how do I know this? Well, we have an agency in LA called the Department of Public Health, whose job is to track the health of people who live in the county. And they publish this report on a regular basis. So anyone can go online and pull down these statistics and see what's happening with people who live in this community. We have high rates of hypertension, diabetes, heart disease, behavioral health conditions, and substance abuse. 31% of adults report their health to be fair or poor. 30% have no regular source of health care. And 45% report having difficulty accessing care. So this all sounds pretty grim, but there are a few rays of hope. And one of those rays of hope is our new hospital. Opened in 2015, is a state-of-the-art community hospital called Martin Luther King Jr. Community Hospital. It opened as a result of a unique public-private partnership. It brought together the County of Los Angeles that built a beautiful modern facility, a private organization that governs and operates the hospital. We bought the most modern, advanced technology and equipment. We opened this hospital as an all-digital hospital with an electronic health record system, no paper, fully integrated biomedical equipment. Beautiful hospital, very safe and high quality. And we partner with the University of California, another public organization known for running some of the best medical facilities in the country. And our partnership with the University of California brings us some of the best medical talent in the country. We have some of the best doctors on our staff as a result of that partnership. So through this unique public-private partnership, we have this beautiful new hospital. And we have an innovative medical campus. So with the hospital as an anchor, good things have radiated out from that, including a connected system of care that includes both inpatient and outpatient care, and some innovative approaches to care, including a 24-hour-a-day, 7-day-a-week psychiatric urgent care facility, so that now, instead of taking people straight to jail, they can take people who have mental health problems to get medical care on the campus. A homeless recuperative care program, so that instead of having homeless people dumped on the streets of Skid Row, we now have a place where they can go and receive safe care when they get out of the hospital. A public health facility, and soon to come, a biomedical research hub and an innovation center. And all of this the result of that partnership between political leadership, public advocacy, public funding, and the private sector. Our hospital is a private community hospital run by a private board, but it's on a public campus. And it shows what can be done when the public side and the private side come together. So what have we been doing since we opened? Well, as soon as we opened our door, we were overwhelmed with patients. We're a small community hospital, but we have one of the busiest emergency departments in the county. We saw over 60,000 patients in our first year. We just finished our first year, and we're on track now to 70,000. Why do we see so many people in our ED? Well, it goes back to what I told you before. We don't have physicians in our community. So 40% of the people who come into our emergency department have what we call low acuity conditions. That means that if they lived in Beverly Hills or West LA, they would go to an urgent care center or to a doctor's office. But because they live in South LA, they have nowhere else to go. So they come into our emergency department. We see young people who have very advanced conditions. We have people walking into our hospital telling us they haven't seen a doctor in years, and they have the pathology to prove it. We see that every day. Our physicians are shocked at the level of health conditions that they are seeing in our community. I'll give you one small example. We recruited a wonderful urologic surgeon to come and work at the hospital, Dr. Stan Frencher. Dr. Frencher finished his medical training at Yale. He was a chief resident there. And through a partnership with the University of California, we recruited him to come and work at the hospital. He tells me about the patients who come into his clinic. These are people who've had kidney stones for years, untreated. They've had stones for so long, they now have permanent kidney damage. They had no urologist there to take care of them. Now that Dr. Frencher is with us and the hospital's open, he is removing those kidney stones, and he's saving people's kidneys. That's an example of the real impact that lack of health care has on people and communities. We're also recruiting and eventually will be training physicians. We're serving as a community resource. A hospital is an important anchor institution in a community. As a hospital, we can lead on a lot of issues that are not just health care, but that radiate out to those social determinants of health. So we have programs to help residents enroll in health insurance programs. We have education to teach people about the health behaviors they need to engage in and to connect them with outpatient medical resources. And we collaborate with community organizations. Aziza said the word collaboration. Collaboration is one of our core values. And without collaboration, we wouldn't be able to do our work of improving the health of the community. And so that means that we're not just working on healthcare, but we're also working on things like housing. There's a housing project in our community called Jordan Downs. It's been there a long time, very run down. very substandard housing. It's going to be torn down, and we're part of a collaboration that is working to replace that housing development with mixed income housing and retail space. It also means addressing food access. You know, in our community, there's nowhere healthy to get a meal. That doesn't promote healthy behaviors. What we do have a lot of, though, are liquor stores. And you can imagine how much that helps the health of the community. And then by also being an employer. I was employee number 1. We now have over 1,200 employees at the hospital, over 80% of them people of color. And building a connected system of care and building out the needed infrastructure. One of the projects that we're working on right now is development of a medical office building so that we have somewhere to recruit physicians to practice in this community. So that's the good news, but there are still some challenges, and I want to say a couple of words about those challenges. We are thrilled to have the Affordable Care Act passed. Before the Affordable Care Act, many people who lived in our community didn't have health insurance at all. Now, post-ACA, less than 10% of the people who come into our hospital are uninsured. And even that 10%, there is some coverage for them. So the Affordable Care Act has made a huge difference. But even though we have the Affordable Care Act and our community has insurance, they still don't have good access to health care. It doesn't help if you have insurance, but there are no physicians to take care of you, and no clinics to go to, and no urgent cares. So even though our community has insurance, we still have a very significant lack of health care in that community because we don't have physicians or nurses to take care of people. And one of the policy issues I want to talk about is what we can do to increase the number of healthcare professionals in our communities. Both Democrats and Republicans love to fund federally qualified health centers, and federally qualified health centers have done a great job of reaching out to underserved communities and providing a lot of the care that they need. But what I want our policymakers to know is that it's not enough. People who live in our communities deserve more, and they need more. They do need primary care, but they also need specialty care. They need surgery, as I just talked about our new surgeon and what he's been able to do in our community. They need skilled nursing facilities. They need home health care. They need pharmacies. When our doctors write a prescription in our pharmacy and they give it to someone who's discharged, that person has nowhere in the community to go to fill that prescription for a painkiller. So we need a lot of other infrastructure in our community as well. So what can our policymakers do and what can you advocate for? Well, I would say that first, advocate for more healthcare professionals. We have health insurance, we have a beautiful new hospital in our community, but we still don't have enough doctors. We're still missing 700 primary care physicians and 1,000 specialists. We're in a position to help, but we need support. 70% of the people who live in our community are insured through Medicaid. Medicaid is the poor stepchild to Medicare. Pays very low rates to providers. Providers coming out of medical school with huge debt can't afford to locate and practice in a low-income community and take Medicaid rates. It's just not sustainable. So we need to find ways to not only support training of more healthcare professionals, but also to support them in locating in low-income communities. We need to extend our funding not just to community health centers and federally qualified healthcare providers, but to other providers who are filling in some of those other gaps in the continuum of care. And we need to make sure that Medicaid, which is the program that primarily insures low-income minorities, doesn't get second shrift to Medicare. The federal government is responsible for both of those programs. A lot of focus on Medicare, but not enough on Medicaid. We need to increase the rates that providers are paid so that people in low-income communities will have access. And we need to make sure that Medicaid programs are included in the health delivery reform initiatives that are led by Medicare. So those are some of the things that I think we can do to address some of these problems. And next, you're going to hear from other members of the panel who are going to talk about some of the other social determinants. Thank you.
Dr. Batchelor, I have a couple of questions that I wanted to ask of you. First of all, could you speak a little bit more about what a real public-private partnership is and how beneficial it could be? Not only, you've shown that it's beneficial where you are, how it could be beneficial to others.
Well, I think the beauty of a public-private partnership is it can bring together the power of government and public funding with the ability and expertise and know-how of the private sector to tackle some big problems. And in our case, the hospital that I operate is located on a publicly funded campus, and the facility was built with public money. The governance and the operation of the hospital is through a private community organization. Some of the other facilities that I talked about on the campus are also through public-private partnerships. So I think it's really the marriage of the power of government with private organizations, and both their know-how and their funding.
Is there representation from both parts on your board? Do they both have a say in the governance of the organization?
So our organization is privately governed. So it's a community board, just like any other private community hospital. We are accountable to the public side through a contract, an agreement that we entered into with the county whom we lease the hospital facility from. As a not-for-profit organization and as a community hospital, we're also accountable to all of the regulatory bodies and agencies that not-for-profit organizations and hospitals are accountable to. But the private governance was part of making the hospital work.
Please introduce yourself.
Hi, I'm Dr. Greg Buchert. I'm currently the Chief Medical Officer for HealthNet California, and previously the Chief Executive Officer that started Centene's first health plan in California, California Health and Wellness. And I'll give a little bit different perspective on the public-private partnership that here all of you are, or many of you are either elected officials or staff for elected officials. And there was nothing more powerful to get me to move as a CEO than to get a call from the mayor of Sacramento that would say, Greg, I would like you to participate in X. Greg, I'd like you to contribute to Y. Greg, I need you to hire challenged youth and veterans. Greg, I'd like you to, and I think 10 out of 10 times, because he's a very persuasive fellow.
It's hard to say no to Mr. Johnson.
Yeah. I responded. And so I think one of the take-home messages is that sometimes all you have to do is ask, and you'll be surprised at how frequently people will say yes.
Are there any questions from our audience for Dr. Batchelor? I have one more. You also spoke of the ability for there to be a partnership in terms of mental health and not putting folks directly in jail. What about the training for those people? Is there training, ongoing training for the individuals that would put them in jail as opposed to bringing them to the hospital?
Yes, I think that part of the success of that approach is having the law enforcement officials trained so that they know how to intervene appropriately and where to take people. And it is making a difference. On the other side, though, there aren't enough trained mental health workers. So about 10% of the patients we see every day in our emergency department have psychiatric illnesses, but there are no psychiatrists in our community. So that's part of that lack of healthcare professionals, the need for mental health professionals.
Thank you.
Now, are there still, a standard amount of nurses and doctors that are actually graduating from college in the area? So there's really not a lot in the whole city. It's just in that community that you're not receiving physicians that want to transfer to that area.
That's a good question. You're saying, why is there a shortage in this area? And I'd say it's a combination of two things. One is the fact that it's a low-income community, which means there isn't a lot of money and there isn't a lot of medical infrastructure, so there aren't even a lot of medical offices in the community if doctors wanted to come and practice there. They can't establish a practice because most of the people who live in the community are either uninsured or have Medicaid, and you can't sustain a medical practice on the payment rates that are paid by Medicaid. And then I'd say the other half of the problem is that we're not training enough minority healthcare professionals, because we know that minority healthcare professionals are much more likely to work in minority communities. So we need to get more minorities in medical school and in nursing school and in other health professions so that we will have the workforce to come and locate in a low-income community like that. Our hospital is willing to subsidize compensation for healthcare professionals, but we have to compete with other organizations to get them to come and work in our community. So we don't have enough.
Any other questions for Dr. Batchelor? Dr. Batchelor, thank you very much. I'm so glad you were able to be with us today. Let's give her a big hand. Now, you heard a little bit from Dr. Greg Buchert, who just spoke a moment ago. He is the Chief Medical Officer for California HealthNet, responsible for clinical leadership, quality improvement, and clinical strategies for the health plan serving over 3 million members in Medicaid, Medicare, marketplace, and commercial products. He was also the founding president and CEO of California Health and Wellness, a managed care health plan serving Medicaid beneficiaries, and a wholly owned subsidiary of Centene Corporation. California Health and Wellness began operations in November of 2013, and he serves nearly 200,000 residents in 19 rural counties in California. This man is busy. I'm so happy you were able to be with us today, Dr. Buchert.
Thank you, Aziza. So I'm going to take things up a notch and really tailor my remarks to many of you who are involved in the making of policy and give you some insight into health plans and health insurance companies. And, you know, fortunately, many of you are here insured by United, Aetna, Cigna, Anthem, Blue Shield, and hopefully some of you are the beneficiaries of working with a Centene health plan. Centene is perhaps one of the best kept secrets across America because they believe in communities, and so they individually brand their companies in each one of the states. And they're in, the number keeps changing, but it's because they grow so quickly. I think we're currently in about 27 states with regard to our services, with each one branded that way. So if you had a chance to see a little bit about Los Angeles, I want to make sure that as you're thinking about developing policy, you think about the everywhere that people live. And here we are with HealthNet. We've got about 1.5 million members in the county of Los Angeles. I can share with you from my experience at California Health and Wellness, you know, often think about California, think of, you know, Los Angeles and San Francisco and San Diego. Well, we served those 200,000 people in rural and frontier counties of California where there's 28% unemployment. We had one county where there is no bank, no high school, one traffic light, and one retired physician. So as people talk about narrow networks, it doesn't get more narrow than that. And so we've got people that are driving 75 miles to get to the closest primary care provider. And so we need to make sure that we're sensitive to all those areas. So let me share with you a couple thoughts here. So let's talk about what the role of a health plan is and health insurance company in a community's health. And you know the health companies and health plans, we contract with hospitals, we contract with physicians, we contract with therapists, and do a lot of things like that. And so that aspect, I'm just going to go beyond. I want to bring things up a notch. Here we are, we just finished the Olympics. I think we're still in the middle of the Paralympics, and a lot of competition among countries. Well, we hear so often that, healthcare in the United States is the best in the world. Well, I'll bring this in to challenge you, and, chances are you've seen some of these statistics multiple times. This happens to be from the Commonwealth Fund that shows out of these developed countries, we rank 11th. If you look at other statistics, we've got typically range about the 37th out of all countries. I think we're somewhere in between Slovenia and Estonia or something like that. But it's so we challenge, so we need to challenge on, do we have the best health care? And at the bottom, you'll see that, not only do we not have the best health care, but we do spend the most. And as policy people, chances are you've seen some variation on this slide, more times than you want to count, about how the United States spends the highest percentage of the gross domestic product on health care. And you look at all these other countries that have better health statistics than us, and you say, what's going on? We're spending a lot of money, but we're not making as much of a difference as these other countries. Well, one of the slides that you might not have seen yet is this. If you look at health and social care spending as a percentage of gross domestic product, there you see the U.S. with the high percent of GDP, but low percentage of expenditures on social care. And so this is where we really stand out from the other countries in a very different way. And perhaps this is why we don't have the great health outcomes that we'd like to see on average. And Dr. Batchelor touched on this as far as, the things we spend money on, they're in the middle as far as influencing health outcomes with regard to access to care, quality of care, doctors, hospitals, health plans, impact so little of somebody's eventual health outcome. And, there are some health behaviors that we obviously try to influence and curb, but it is the social determinants and the impact of the community in which somebody lives that influence these health outcomes. And a lot of the health disparities, the very specific details that Dr. Batchelor pointed out. And so, I'll throw the gauntlet down to all of us as, in the health plan world, of needing to do something differently from what we've done before. And this is where I look to all of you and the people that you work with and the constituencies that you represent to do something as well. And so I want to touch on 6 themes that give you the inside view of health plans, of what works and what doesn't work. And one of the things that's real exciting is that I am part of Centene, and I think that they really do have a best practice for so many things in the area that we'll touch on with regard to their impact on the community, because they do take this whole person view of health. It's not just the physical body, but it's the it's the education, it's the nutrition, it's the environment, and so all those things impact the community. So one thing is that members, we have members, but it was interesting when I when I interviewed at Centene, it was the CEO of Centene that said, Greg, we don't take care of members at Centene. We take care of individuals who live in families, who live in communities. And unless we understand that, unless we focus on that, we're going to miss the mark. And as such, I think you'll see that a number of things I'll mention focus on that very issue. As we look at members of health plans, when you think that in California, 1 out of 3 people is insured through Medicaid, 50% of babies are born to mothers who are insured by Medicaid, but then you add in Medicare, you add in VA, TRICARE, the federal employees, health benefits program, all of a sudden you're talking about easily 2/3 of the population is insured by some type of public funding. And again, many of you are associated with the source of this public funding, and so it gives you an opportunity to influence what happens there. With regard to financial discipline, we are tasked with being fiscally responsive and trying to do things that make a difference and do them economically, cost effectively. But there are, from a health plan perspective, it's interesting because, especially for publicly funded programs, we are funded based on a number of different formulas. And I'll give an example in California. As a health plan serving the most Medicaid members in California, the way that our rates are set by the state are a function of how many services are used and how much did they cost. Well, the services that are used, the state only counts those things that are Medi-Cal benefits, Medicaid benefits. And so as you have something that, as you define what those benefits are, you hear Dr. Batchelor talk about some of those things that are going to make a huge difference in the community. And one of the examples I'll use is recuperative care. So if you have somebody that's homeless in a hospital and they need a few more days of IV antibiotics, they need to make sure they're taking their medicine, they need some additional wound care, but they don't need a hospital bed for that. The system isn't set up to provide access to recuperative care for those things to occur at a much lower cost, get somebody back into the community and closer to family or other acquaintances. And so, if, as a health plan, here we are in that decision to say, do I do something that's going to cost less, or do I continue to keep somebody in the hospital because that will get figured into my rates? And so you have this tension that's always going on as somebody's making those types of decisions. Clinical and service quality. I think everybody wants to see that Nordstrom level of service or Disney level of service, whatever it may be. And we measure that, and it's actually pretty easy to, in some ways, to look at member satisfaction or all too often member dissatisfaction. But the clinical quality, it's a challenge. It's a lot easier to measure process, such as did somebody with diabetes get their hemoglobin A1C measured? It's a whole lot different to say, did it make an impact? Did that hemoglobin A1C come down? Are they avoiding the long-term sequelae of kidney disease and blindness and neuropathy and amputations, other things like that? And how effective are we at taking care of them? We don't have the ability, as a physician and knowing lots of physicians, you can come to me and say, who should I go to get my knee replacement? I can tell you that whether somebody went to medical school, who the doctors think is good, who is well connected, but it's much, much harder for me to say, here's the person that can do the surgery to get you out of the hospital the fastest and get you back, active and at work the fastest and with the greatest level of satisfaction. And so just the measures that we use to evaluate what we're doing needs some modification. Innovation. That's one of those things that, we often get stuck in a rut of
let's do things the same way we've always done them. And there's a lot of challenges in terms of the, as a health plan executive, I'd say 10 times a week I get solicited by somebody with a great idea and something that's new and interesting and innovative. But it's the, again, comes out the decision. Is this a covered benefit? When does this fit into the planning, into the information technology strategy? Because we're changing systems, we're doing upgrades, we're doing various things like that. How do I measure the impact on it? And how do I choose between the 5 different, shiny things that came? And how do I differentiate between somebody's got a really slick PowerPoint and is very charismatic versus somebody's got something real that's going to make a difference? And so, we're looking at those types of things. But, in our rural communities, in California, we have pursued a lot of the telehealth activities. And so we do have people that are talking to their physicians on their smartphones. We know the communities we serve, the majority of people not only have a phone, but have a smartphone. And so they can get video and get messages. We have electronic consults for the physicians in these areas where instead of if you go to the academic medical centers, you have that dining room conference and those curbside consults where you see all your specialty friends. Well, these folks that are out in the rural areas or in isolated areas, they don't even have to be rural.
South LA.
Yeah, South LA is absolutely as isolated as Alpine County I was describing earlier. So you can get the consult from the person that you can't get the physical access to. We have virtual interpreters that, instead of paying for somebody to drive 3 hours to go to an appointment to help somebody who speaks Urdu, we can have somebody that's comes up on their laptop at the center. And so there's lots of things that we can do, but we've got to be selective and smart about how we implement innovative activities. And then there's the community. At Centene, our purpose statement, people talk about mission and vision, and values. Well, we have a purpose statement about why we exist, and what it is transforming the health of communities, one person at a time. And so, a couple things examples of what Centene does that makes a huge difference is, one is we're actually about to launch a program called, Strong Youth, Strong Communities, where we have look at the youth of today and how do we empower them to do better things and how to take charge and take responsibility for their health and the community's health. The CEO for Centene is chairman of the board for the National Urban League. And I'm proud to say that there's, 3 of our chapter presidents, 3 of our state presidents are on the boards of their local urban leagues. And it's that whole concept of how do we help organizations educate, employ, and empower individuals who have had challenges in their life. And we think that's important to improve the health of the community. We sponsor anti-bullying events. And so we have, not only, it's not because we're going to avoid an ER visit or somebody gets beat up in the playground. It's because we're investing in that person 20 years from now that they don't grow up emotionally scarred and have the challenges of behavioral health issues. And so I think you'll see that the role of a health plan in the community, is starting to change and needs to change much more dramatically. But with that role of the health plan comes some challenges. We know that there are limited funds. We know that nobody likes to see double-digit inflation or rate increases in their premiums that they're paying. And so there is competition for both for membership as well as for controlling cost. And so as a health plan executive, I'm always going to question, do I invest in my community? Because if I make that investment, I'm not only helping my members, but I'm helping the members of every other health plan. And so it's how do we get the health plans to work together to collaborate again, that collaboration of, so everybody should be pitching in to help shore up the community. And so as you're looking at, again, those policy activities or those public-private partnerships, those are the types of things that you can and should be driving, because it's one thing to, because you want to make sure that everybody's on the train and everybody's contributing. And it's those types of collaborations that will help make a difference in building up the communities and the health of the community. And with that, here we are as, one cog in the wheel here, but and I'll stop here. So thank you very much.
I do hope that you're able to see the need for collaboration, and I think that you're going to be hearing that theme over and over and over again as we go through this process, this workshop this afternoon, that we just have to get out of working in those silos, that we're not going to get very far if we continue to work in that light. We've known it hasn't been working, it's not going to start working, and so we need to find another way to do that. And one of the ways, I wanted to ask you, Dr. Bueckert, if you could talk just a moment and explain to us what social care is. What do you mean by social care?
By social care, it's I'd say it's the things that are outside of routine services provided by doctors, hospitals, therapists. It's doing work with community-based organizations and, partnering with them to help identify what are issues and helping spread the message, and actually sometimes be those apostles out in the community delivering messages of how to improve health care. Social care, I think about of housing. And so you've got great examples in San Diego. There's actually just a new study that came out from Utah that showed if you get people into stable housing, their health improves, their substance use issues improve, lots of other things happen when you give them a stable home. And those are things that health plans don't typically pay for. And it's something that I would argue that we probably should start making some investments and partnering with others that want to make those kind of investments.
Any questions? Yes.
I have a question. Regarding the graphs that you showed in the very beginning of your presentation, do you have anything that shows how the U.S. ranks now? Because it seems to be, after the Obama plan was created in 2010, I would think that some things on that graph would be different.
Yeah, no, I think you're absolutely right that it will be changing. I haven't seen anything very recent about that. It's about every 5 years that they kind of look at how does the U.S. compare to other countries. And so that's, I think, in some of those statistics, it takes a long time to start capturing the impact of somebody actually having access to health, and such as take a patient with diabetes. It takes a long time to say that they're in stable treatment and avoiding those sequelae that happen 5 years, 10 years, 20 years down the road.
And if you think about part of the message that we've both been delivering about all of the other non-health care related determinants of health, we're not going to see those numbers change dramatically until we start to change some of those other things that are influencing health, the social and economic determinants. So I wouldn't be surprised if it still looked very similar.
Yes.
Hi, my name is Nicole Scott Harris. I'm an environmental justice worker out in Newark, New Jersey. I'm also trained.
Yay, Newark.
I'm also trained to be a registered dietitian. So I have two questions specifically relevant to my perspective is how can doctors advocate for more preventive health care that's outside the realm of their expertise? Doctors traditionally get very little information about nutrition, but they're still tasked or try to give nutrition advice. Even nurses don't necessarily have that educational background or qualification. And then secondarily, what is the role for physicians in speaking up for environmental factors that affect people's health, especially in the case of something like diesel? I work in a poor community. Diesel has been classified from the World Health Organization as a carcinogen, which means that it accelerates the pace of cardiac disease. It can aggravate diabetes as well as respiratory issues. Cancer.
So I'd like to try to address both of your questions. The first one was about food and nutrition, et cetera. And I guess what I would say is that we've sort of entered a new era of healthcare where doctors are beginning to realize that they are only one member of the healthcare team, and that healthcare really needs to be delivered by a team of health professionals. And that includes people who have expertise in food and nutrition. So I think rather than doctors thinking that they're going to do everything, we're starting to realize that we need to have a whole team of people that includes doctors and nurses and pharmacists and social workers and dietitians to deliver good health care. On the second question about environment, I also think we're starting to make a shift from only focusing on individual health to focusing on population health. And when we focus on population health, we think about all of the factors that contribute to good health for a community and a population, and that includes, the physical environment, exposure to toxins, and the social environment, and all of those determinants of health. One little example of something that I'm working on as a hospital, and that is the liquor store that's down the street from my emergency department. It's not a medical intervention, it's a social intervention. But I'm working with our local elected official to get that liquor store turned into something else, like a place where people can buy healthy food. So I think that we're starting to expand our view of healthcare and health so that we don't just look at individuals, but look at communities and populations.
And I think that that is an absolutely wonderful, thank you for the question. It's a great segue into this collaborative effort, because we're going to talk right now a little bit about how the environment can be a little bit more proactive, and what we can all do to participate in that. And with that, I'm going to introduce you to Leonard E. Robinson, known as EnviroBro. I love saying that. Leonard Robinson is the president and senior strategist for EnviroBro LLC, a sustainability communication and consulting firm located in Prince George's County here in Maryland. You stole him from us. He was from California, from Sacramento. He is also the host of the weekly Green and Sexy radio show that broadcasts on D.C. area radio station WERA 96.7 FM. Prior to moving to the East Coast, Mr. Robinson served as an appointee under current California Governor Jerry Brown and former California Governor Arnold Schwarzenegger as acting director and chief deputy director of the California Environmental Protection Agency, Department of Toxic Substances Control. I had the pleasure of being on his radio program with him last night. We worked together in California, in Sacramento, on a local radio station, KDEE, which is part of the California Black Chamber of Commerce Foundation, and he did a program on environment and I did a program on health, and so oftentimes we worked together, and it was good being back with you again last night. And so without further ado, let him talk a little bit to you about the environment.
Okay, let's see if I can figure this out. I'm the oldest one in the room.
No, I don't think so. I think I got you.
Oops. Okay. That's not it.
Patrice?
Oh, here it is. I can fix everybody else, but I can't fix mine. Okay. Anyway, my name's Leonard Robinson. Yeah, I have the nickname EnviroBro. Where that came out is probably, I'm a baby boomer, probably one of the few baby boomers in the room. When internet first came out, you had to get an email address, and it says, your email address would say a little bit about yourself. Well, I've been in the environmental field like forever, and I'm a brother, so EnviroBro. So it was EnviroBro at prodigy.net. Okay. The other baby boomers just spoke up. And then I advanced to EnviroBro at AOL. And then I finally settled in at Hotmail. You can tell us OGs because we use Hotmail and Yahoo still. But that's okay. I call myself an OG with 4G. The title of my talk is Black is the New Green. I've been in the green field, again, it's over 40 years. That's all I've ever done. I worked out at a sewage treatment plant, worked my way up to working for Arnold Schwarzenegger. What this is about, I'm going to tell you what I'm going to talk about. And we know about environment. We just had a talk about health. We talked about diabetes. We talked about, all the different diseases attributed to the environment. We talk about, we know about contamination. We know about climate change. What I want to talk about is the opportunities in joining something called the green economy. Unfortunately, whenever there's an environmental issue, African American communities always get the brunt of the worst part of it. The disproportionate part of the pollution, the climate change, and everything else. Well, it's time to change the tide. We rely almost too much on government. I work for government, and that term bureaucratic solution is an oxymoron. That's like military intelligence, Fox News. It doesn't work. During his speech, and then Alice Walker wrote a book called "We Are the Ones We've Been Waiting For." For the last 7.5 years, we've had an African American president who put climate change at the very top of his agenda, addressing climate change. He couldn't get anything done in Congress. That's okay. He used an executive order to get it done. He wasn't going to wait. I'm a little bit disappointed on the engagement of African American community in climate change. But Aziza brought it back. She says, a lot of times we weren't invited to the table, because as you know, if you're not at the table, you're on the menu, right? Well, Aziza and I discovered what Prosper is going to do is we're going to bring our own table. That way we can invite who we want when we want. So we went from the outside to inside, and I get to talk about environment. As I look on the list of stuff, again, African American president, this is the Congressional Black Caucus Foundation Annual Legislative Conference. I don't see that much talk about environment. Now, we'll hear about environmental justice, which, okay, these are the things that happen. We know there's terrible things happen. Where are the opportunities at? Our African American elected officials, they're busy. Well, we need body cameras for the police. We need more military type stuff for the police. We need gang intervention. Yeah, we do, but you know what? I'd rather have a company that made body cameras in the community giving jobs than having the police giving it to the police, to help out the police. I really think if we have more employment, more opportunities, somehow when opportunities in employment go up, crime goes down. Wow, isn't that amazing how that works? But we keep taking care of the symptom and not the cause. So you're going to find out, we're going to talk about the green economy, we're going to talk about some of the opportunities, and you're going to find out that I'm pretty passionate about the environment as well. I come from an old school parents, and they got me started my environmental career. Simple thing. A lot of you baby boomers heard it. Always leave your room in better condition when you left than it was when you got there. I decided to make my room the environment, so that's what I've been doing. It's trying to improve the environment, and part of improving the environment is showing opportunity, not only cleaning the air and cleaning the water and cleaning the soil, but showing us opportunities to do so. This crap is in our communities. Shouldn't we benefit by the cleaning up of it and the recycling and all the good things that come out of it? This is my motivation. My three children on the left, Ryan, Colin, Lacey, all graduated college. One graduated magna cum laude, other graduated summa cum laude, the other one graduated thank you laude. But they graduated. And I have two grandsons. I have DeMonte and my 6-month-old grandson Will. So this is why I want to make this room leave the room in better condition, because I have more time behind me than I have ahead of me. We don't own anything. We're just stewards of stuff. So I'm trying to do my best. That's my inspiration. That gets me going. Sometimes it's money, and as we know in Domino's, all money is not good money, but money is important. Which brings me to the point, I'm a baby boomer, proud of it, born after World War II and before 1964. I'm that generation let me see, I'm that generation that bought you toxic waste landfills, plastic, global warming, and my personal favorite, high fructose corn syrup. We gave Generation X and Y, we gave you all the gifts that keep on giving. All right, now, climate change. John Kerry at a Bloomberg meeting earlier this year in April said that climate change, addressing climate change, is a multi-trillion-dollar operation. He didn't say million, he didn't say billion, he said trillion-dollar operation. Well, wow, if we're only getting 1% of things, well, 1% of a trillion is what, 100 million? That's great. A multi-trillion-dollar operation. It's put out there in front of us. We should really address it, but then we need to be educated. So in the next 10 minutes, I'm going to educate you about climate change and emerging opportunities. Okay, game-changing events. Introduction of creation of fire. That was a historical game-changing event. Invention of the will. The advent and influence of Jesus Christ. Game-changing for the world. The printing press was a game-changing for the world. Flight, the Wright brothers, or whoever, now it's disputed, but flight, that was a game-changing event. The Industrial Revolution, game-changing event. World War I and II, game-changing events. Tuskegee Airmen. I can't wait to go to the African American Museum and see the Tuskegee Airmen exhibit. Another, the Civil Rights Movement, game-changing event. It's not where we want to be, but it's better than we used to be. The internet, just talked about that earlier. The internet came in, wow, be able to talk to people without having to write stuff down. And it's interesting, I remember my parents before they passed away, I could always tell when they were trying to send me an email because I'd get something blank. And then they'd call me up, I sent you an email. Okay, you're calling me up to tell me you sent me an email. Or they used to send me a text and it'd be blank because they couldn't figure out what to do, how to send the text in. But didn't the internet change our lives? You can sit here as I'm speaking, you can buy you a car, you can buy a house, there's a whole bunch of things that you can do with the internet. You can communicate just like that. You can get data. Somebody says something, you can fact check. Whoops, you can fact check just like that. Isn't that great? Internet, definite game changer. In our investment opportunities and everything was a game changer. Well, here's the latest game changer. It's called the green economy. And I'll read the official definition of the green economy. A green economy is one whose growth in income and employment is driven by public and private investments that reduce carbon emissions and pollution, enhance energy and resource efficiency, and prevent loss of biodiversity and ecosystem services. Now, that's the official name. What I see green economy as opportunity. We've got states, California, when I was part of the executive team that put together California's greenhouse gas reduction, AB 32, the Global Warming Solution Act of 2006. I was part of the team there. That was one of the big game-changing pieces of policy